Hello, welcome to our little podcast from Asia, the Arthroplasty Society in Asia. I'm David Chun. I'm your host for the evening. I was past president of the Asia Pacific Orthopedic Association and also several other associations. I'm a retired professor from University of Malaya. Today we have a challenging task. What we need to do is cover the whole history of knee replacement in the world. Then we're going to talk about some biomechanics and some statistics with regards to how long implants last. And to help us with that, we have Professor Yan Chun Hoi, who is from Hong Kong, and he will be talking about the history. I will be talking something about biomechanics and stress testing of implants. And just to show that we're not telling you lies, Richard de Steiger, who's Deputy Director of the Australian Knee Register, which you are very familiar with, is going to be telling you what they have discovered when implants are put out into the real world and they're operated on by real surgeons, and then we see the results. It's no point you talk about biomechanics, no point you talk about stress testing, no point you talk about any of those things until it's in real life. And what Richard will be telling us about is in real life. The final speaker for this evening will be Professor Masood Umar, who's from the Aga Khan University in Pakistan. Pakistan is a little bit challenged because they're a little bit low on resources currently, and they have been for a while, but they have been doing excellent work with pretty simple implants, probably some of the oldest implants in existence, and they're very happy. So please sit back and enjoy. There will be a little discussion session at the end in which you can participate, and I would love if you join us there. Thank you very much.
Hi, I'm going to talk about the history of development of total knee replacement. I'll mention the evolution of prosthesis, instrumentation, and fixation methods. We know the history of total knee replacement dated back decades ago. In 1958, Macintosh invented the hemiarthroplasty prosthesis. These are very rudimentary design and often lead to early failure and loosening. In 1973, Freeman designed this more modern prosthesis. It had the incomplete constraint, which aimed to reduce the stress between the bone and implant interface, but these are non-anatomical design as well. Later on, Shears and Gupa also invented the more constrained hinge-type prosthesis. They did not allow any rotation between femur and tibia. As a result, there was high torsional stress between the bone and implant, and also these would lead to aseptic loosening and failure. And there are also bicompartmental non-anatomical design like these, so-called geometric prosthesis. So for the past design, often there are very few instruments. The prostheses are either low constraint or high constraint. They were non-anatomical, and they did not include any patellofemoral components. I think the milestone of development started with the total Condler knee design. So for this design, there is a functional simplification because the surgery required excision of the cruciate ligaments. They were also more anatomical because they included both the patellofemoral joint and also the tibialfemoral joint. There was high congruency for good distribution of the pressure on the tibial polyethylene. Unfortunately, the prosthesis had resulted in an anterior translation of the femur during flexion, posterior impingement, and also limited knee flexion. So how about the present designs? Which is which? I think for the modern knee design, surgeons are aware of the stability of the joint, which include the articular geometry, and also there are static stabilizers such as the ligaments, and dynamic stabilizers such as the muscle and tendon units. For the modern total knee replacement, we have to have a good wear resistance and also allow balance for the soft tissue structures. We often classify the degree of constraint according to the status of the posterior cruciate ligament. So we can have PCL sacrificing design, PCL saving or retaining design, or PCL substituting design, or we call it the posterior stabilized knee. And in terms of the polyethylene, we can either have fixed bearing device and also mobile bearing device. So on this picture, you can see three different types. On the left-hand side, these are the PCL sacrificing design. So you can see the trochlea of the femoral component is really long. And on the tibial side, there is no post. So there is no cam post design. And in the middle, you have the PCL retaining device. You can see the trochlea is already shorter. There's a high arch on the femoral prosthesis to accommodate the PCL. And correspondingly, on the posterior side of the tibial component, there's an indentation for the PCL. And on the tibial side, it's relatively flat to allow rollback of the femoral component. And on the right side, you can see this is the PS design or PCL substituting design. So on the femur, you see the cam, and on the tibia, you see the post. So we have three common types. And in terms of the tibial polyethylene fixation, you can have the fixed bearing. So the PE is fixed onto or locked onto the tibial component. So the rotation and translation only occur between the femur and polyethylene. As a result, there's a multi-directional wear, and the studies show that multi-directional wear actually generates more PE particles and could lead to acceptor loosening and failure. On this video, you can see micromotion between the PE and also the tibial insert. And when they're disassembled, you can see there is wear, backside wear on the PE. And this would be a source for PE particles. And for the rotation platform total knee replacement, the designers claim that there are actually unidirectional wear between the femur and the PE, and also between the PE and the tibial component. So this rotating platform decouples the multi-directional wear to unidirectional wear, and this would theoretically decrease the amount of PE particles generated. Next, we're looking at the knee kinematics. We know that knee joint is a complex joint. It's not just a hinge joint. So on rotation side, there were used the 4-bar linkage theory. So people thought that the center of rotation is actually at the intersection between the ACL and PCL. And when the knee flexes, the center of rotation would actually go from anterior to posterior and then distal. So based on the 4-bar linkage theory, a J-curve femoral component was designed. So you can see there's a change of center of rotation from anterior to posterior and from proximal to distal. And there's a diminishing or decreasing radius of the femoral component to accommodate flexion and the translation of the femoral component. And later on, there are some milestone design studies to show that actually center of rotation of the knee is relatively constant. So the researchers thought there's a static center of rotation, which is at the transepicondylar axis. The center of rotation is superior to the ACL and PCL intersection. And Michael Freeman had this milestone design study, and they showed that actually the center of rotation is not at the ACL PCL intersection, but at the transepicondylar axis. And there's also a different contact point between the medial compartment and the lateral compartment. So flexion and extension on the medial side, it's relatively static. You can see the contact point does not move that much. But on the lateral side, there's rollback from full extension to deep flexion. The contact point between the femur and tibia actually changes from anterior to posterior. So this is another anatomical study on the human knee joint. You can see from the full extension to deep flexion, the contact point between the femur and tibia on the medial side is relatively static, whereas the contact point in the lateral side gradually translates posteriorly. So based on this, another femoral component was developed, which is the single radius femoral component. So there's less translation at the medial compartment. Also, people would invent some called medial pivot knee design. And on the lateral side, the knee is designed to facilitate rollback. So you can see the diagram shows you a medial pivot knee design. On the medial side, it's a ball and socket joint. On the lateral side, it's a round and flat joint. So this would facilitate the lateral rollback and the medial pivot. So I think about 10 years ago, some doctors invented the kinematic total knee replacement. they believe that the natural knee has 3 axes in terms of knee kinematics, which is the green one, is the central rotation of the tibia on the femur. It is through the transepicondylar axis. And then you have the magenta line, which is the center of patella flexion extension on the femur. And also there's orange line. They believe it is a medial pivot, so it's through the medial femoral condyle. So, and we also have the yellow line, which is the joint line. So they believe that the magenta line and green line, they're parallel to the joint line, and the orange line is perpendicular to the joint line. So these are the 3 axes of the knee kinematics. And for the kinematic alignment, total knee replacement, they wanted to restore this natural patient-specific joint line. So you measure on the pre-op X-ray, and intraoperatively, you can either use patient-specific or robotic instruments, or you can use conventional instruments to restore this patient-specific joint line. And they believe that these joint lines would facilitate knee kinematics and make patients' functional results better, superior to what we have the average mechanical joint lines. Based on this concept, I think nowadays we have more modern kind of total knee replacement. For example, this specific knee prosthesis, they constitute a 3 degrees of physiological joint line in their prosthesis by designing a femur and tibial insert with uneven medial and lateral side. So you can see that the lateral side, the PE is thicker and the metal is thinner. So as a result, you have a physiological 3 degrees of joint line obliquity. And not only the 3 degrees of physiological joint line, they also had this anterior cam and posterior cam. So the anterior cam would replace the function of ACL, and the posterior cam would replace the function of the PCL. So they call this bi-cruciate stabilized knee design. And on the tibial insert side, the medial side, the tibial insert is concave, so facilitate medial pivot. And on the lateral side, the PE insert is convex, so that would facilitate rollback. So all these designs would try to mimic normal knee kinematics. So on the instrument side, we used to have conventional instruments, but I think decades ago there were computer navigation, and we also had patient-specific instrumentation, and nowadays we have the robotic-assisted total knee replacement. But because of the time limit, we could not explore more on this instrumentation. And finally, a few words on the fixation method. I think the majority of the total knee replacement we did were cemented, but I think recently we also have the cementless fixation. So short to intermediate terms, results show that actually the survivorship of cementless prosthesis is at least comparable, if not superior, to cemented prosthesis. So I think the development of total knee replacement involves a long process of evolution. Trials and error were required to improve the design. We need to use evidence-based medicine for a better total knee replacement prosthesis, and the design process involves both the surgeons and engineer. So what is an ideal total knee replacement prosthesis? Do we need to follow patient-specific alignment, or do we need to have a patient-specific prosthesis? I don't think we still have we have the correct answer yet. And how far away are we from the forgotten joint? I think that will the answer is open, and that will leave us all to improve our techniques and also participate in more implant design. Thank you very much.
Hi, so let's go back to the history of knee implants, and right back to the time when we were using all poly implants. We instinctively feel that metal back tibial implants are stronger and are more lasting than all poly tibias. But is this true? In my own personal experience of more than 580 all poly TKRs since January 2015, I've had no implant failures yet, despite some very challenging cases like you can see here and here. And some of these patients were quite young and wanted to go back to quite an active lifestyle, and they've managed to do so without causing me too much bother. Bowman and Gio reported their findings in CORR, the Clinical Orthopedics and Related Research in 2000, on 60 patients of age who had undergone primary osteoarthritis knee replacement. And they had implanted identical cruciate retained knees, cemented all poly in half of them, and cemented metal back in the other half. Of the 324 patients that were enrolled, 324 knee replacements that were enrolled, 213 of these had an adequate length of follow-up of a minimum of 3 years. 100 of these were all polyethylene, and 102 were metal back tibias. They found that there were 13 reoperations for various reasons, but none for aseptic loosening or wear. You would expect this because this is a 3-year-old study. And more importantly, they detected no difference in clinical scores between both patient groups. So they concluded that, in fact, because the all-poly knee was cheaper, this was probably the way to go. When they looked in the literature, they found 5 other papers. I'm just blowing them up to show you that all these papers also found no difference between the groups. 10 years later, they went back to study the same group again, and they also had discovered no change. So in fact, that study shows that this difference does not exist between the two groups even up to 10 years. This is an RSA study from Gothenburg in Sweden. 40 patients had AGC knees identical in every way, except that half of them had all poly knees and the other half had metal back knees. Now, I'm just going to show you with the laser pointer. This is the all poly group. And you can see here that at 3 months, the subsidence in the metal back group was far more. At 12 months, this was more accentuated. And at 24 months, the subsidence in the metal back group was far outstripped that of the all poly group. So their conclusion was that there was better initial fixation of the all poly than the metal back group. And this was because probably the metal back group needed larger cement bone contact area to resist clinical eccentric load because the tray could not distribute the load equally. The all poly being more elastic probably absorbed the forces through the poly much more and then transmitted them more evenly to the cement, resulting in less migration. You would imagine that the implant on the left, this one here, which is identical to this one where the surface and the poly are concerned, just difference in the tibial side. On this side there's a central stem and 2 pegs, and this side there's only just 2 pegs without a central peg. So you'd imagine that this was more stable than that. But if you perform an RSA on them, this tray is represented here in terms of implant migration. So you can see that 4 months, 12 months, and 24 months, there's significantly more migration of this implant than this one. Similarly, for subsidence, this implant here subsided far more than that implant at 4 months, 12 months, and 24 months. And it also rotated more, both in the AP axis and the internal and external axis. So, therefore, we would say that there's some difference, at least, between metal back tibial components and all polytibial components. But what about the metal you use? Does the tray material matter? So this is an interesting study where there were 3 groups of patients. 50 of these patients had all poly knees without a tray. 50 of them had a titanium tray, and 50 of them had a cobalt chrome tray. And in this group, you could see that the cobalt chrome trays had significantly more medial tibial bone loss than the other 2 cohorts. So that there was more bone loss on the cobalt chrome, which was much more than the titanium, and the all poly had the least amount of bone loss. Now, in addition to that, the all poly cohort had higher final knee scores and the least amount of stress shielding compared to the 2 others. Here's an interesting study by Rob Nellison from Holland. And it shows a summary of all known RSA studies. As you would expect, there is a difference between cemented and cementless. There's a difference on the coating you apply to the metal implants, and slightly between the time you inserted the cement, which age it was, what kind of cement it was, and the kind of technology that was used. But they certainly found no difference between the all poly and the metal backed tibial inserts, and also no difference whether it was cruciate retained or posterior stabilized, or whether it was mobile bearing, or if it was fixed bearing. This is the summary of what they discovered when they looked at so many different meta-analysis. They found that actually most of the studies favored all poly as opposed to metal back implants. So that's very, very interesting. Meta-analysis seems to favor the all poly component, and so does the cost. So what about other bearings? How about if, you saw it in that summary just now, but how about cruciate retention, mobile bearing, medial pivot, so on and so forth? Does it really make a difference? It's very interesting because Richard will be talking to us about it following this, and you will gain some information from him. I personally have always retained the PCL because these cases that I do are very challenging, and if I don't retain the PCL, then there's hell to pay. Everything becomes far too loose for the patient's own good. Actually, again, when Richard gives his talk, he will tell you that cruciate retained knee replacements seem to have a better longevity on at least his register, and in fact almost every other register as well. For example, this is the PFC sigma, and you can see that the percentage of failures is slightly higher in the posterior stabilized group as opposed to the cruciate retained group. But if it's a mobile bearing tray, then the failure rate actually increases rather than gets less. And here are the actual numbers in that graph. Yes, cruciate retention is one of the largest number of patients in the Australian registry, and this is where the data came from. But let's look at the UK registry. This is cruciate retention. This is posterior stabilized knees. And this is mobile bearing trays. So the UK registry pretty much says the same thing as the Australian one. If you add a posterior stabilized mobile bearing tray, it's the worst of all. Why is this so? I mean, people will tell you that rollback is not a good thing, it's a good thing, and that paradoxical sliding is a bad thing. And so you will want to put some kind of cam and post thing to prevent this from happening. Right? But don't forget, shearing forces also occur at the cam and post, and that's a very much smaller area, and that's occurring at the time of flexion of the knee, which is a big stress on the cam and post mechanism. That creates point stress here and eventually wears away your post. And the cases we do are very challenging, right? Most of our cases present like that. They present late with very unique features. They have very bowed tibia. There's a lot of torsion of the leg. But if it's done well, you end up with a reasonably good result. You don't do so though if you actually sacrifice the cruciate ligament. So patients are likely to get better results if you use a simple cruciate retained knee replacement than any other design. Thank you very much.
It's a pleasure to speak to you tonight at the Asian Normal Seminar on knee replacement, and I'm going to talk to you largely about joint registries and what they have to say with the results of these. In my declaration, I have no conflicts of interest. David's briefly touched on my role, but I'm a Deputy Director of the Australian Orthopedic Association National Joint Replacement Registry, and I've been fortunate enough to be President of the International Society of Arthroplasty Registries. But today I'm just going to speak about my own registry, the Australian. We started in 1999, directed by Professor Stephen Graves, and still going strong after 21 years. We had full national data from 2002 on all hip and knee replacements, and from 2008 on all shoulders. The purpose of a joint registry is to define, improve and maintain the quality of care of individuals receiving joint replacement surgery. And we use observational data with few, if any, exclusions. And what that means is it gives you real-world information on all surgeons performing joint replacement, not just a bunch of experts, perhaps like us talking to you, but information on what happens with prostheses amongst a whole national experience. Data validation is a very important part of the registry, and that's so people can be happy that the data we present is true and validated. And we use a sequential multi-level matching process against state and territory discharge data, and when we do this each year we have almost a 100% data match. We present the data by yearly cumulative percent revision, and what this is a survival plot of the proportion of subjects who have not yet experienced a defined event. That's either death or revision versus time. We use the Kaplan-Meier method with confidence intervals and an accepted statistical method, and we present a curve to show the proportion revised by a certain time rather than the proportion surviving, which the Scandinavian registries largely do. These couple of slides are used to illustrate some of the figures that I'll be showing you a little bit later. So we show figures of cumulative percent revision of devices and use hazard ratios with 95% confidence intervals to compare the different groups. And a hazard ratio is an estimate of the instantaneous risk of an occurrence of an event, for example, a revision at a time point t, and that's how we compare the actual groups that we are showing you. This can be either for the whole time period or proportional for specific time periods. And of course we do adjust for confounders in observational data. So I can use an example here of a slide. This is an example of a slide, the revision of total knee replacement by sex, male in green and female in blue. We can see at 19 years the percent revision for males is 10%, and that for females is 8.4%. And males always have a higher rate of revision than females, but it does vary in the rate over time. And in the red box we see for the first 9 months, men have a 1.44 times greater rate of revision, but with time, after 1.5 years, it reduces, but always remains higher with males. And this graph or figure is what we'll be showing you coming up now. We can present the data by patient characteristics, age, gender, diagnosis, BMI. We can look at prosthesis characteristics such as fixation, bearing surface, stability, fixed mobile bearings, a whole range of things we can show you. That we have in our time, I'll just touch on a few areas where there are significant differences, and firstly we look at age. Compared to hips where there's not a big difference, knees really have a much higher rate of revision with younger patients as seen in green compared to older patients in red on the bottom. If we look at obesity, infection is in red. We can see as we go from normal weight up to, on the bottom, class 3 obesity with a BMI over 40, infection as a reason of revision markedly increases. And one of the major reasons why obesity is of a concern with joint replacement, particularly with knees. If we look at stability, in the early part of the registry, we found that there was an increasing use of PS knees in blue. But CR knees have always been the most popular, and they've certainly increased with time, along with the increased use of medial pivot design. And one of the reasons I think for that is registries, as David has said, has largely shown a reduced rate of revision with CR minimally stabilised. Here we see our curve. The CR knee has the lowest revision rate at all time points. And remember, these are adjusted for age and gender. You can't just look at the curve on the graph. If we look at cross-link poly versus non-cross-link poly, here we've shown a really big difference with time, as we have shown in hips, that cross-link polyethylene has a lower revision rate and now makes up the majority of knees that we implant use cross-link poly. And finally, just a graph of stability and patella usage. And I'm showing this because if you do use PS knees, you really should be resurfacing the patella, as it has by far the highest rate of revision in red. In green is a CR knee with the patella revised, which has the lowest rate of revision. Now let's get on to all polytibial prostheses, and what do the registries say? Well, firstly, I'll be a bit sneaky and look at the knee arthroplasty trial, the CAT trial from the UK, which was really a randomised trial, but in the format of a very large group of patients recruited for a whole lot of RCTs. They looked at poly versus modular. They had 409 knees, and the Oxford score was the same at 10 years. So in other words, there was no difference in the patient-reported outcome measure. However, they said that polyethylene components were 42% less expensive than modular metal backed. I think that's important. However, this group of patients had higher readmissions over the 10-year time period, and when they did a health technology assessment, it suggested that modular back components were in fact better value for money in the long term because of the reduced rate of readmissions. And that data is available with David Murray, my Oxford colleague, as the lead author. Let's look at the biggest registry-based hospital, and that's the Mayo Clinic. This is an observational study of 16,500 knees from the Mayo. However, probably largely historical here, but the data is less valid. The PFC, as David has used, was the most common knee used in their clinic with all modular poly, and all polytibulars had a lower rate of revision than modular over this study period. When we look at our registry, we've got information on 1,831 all polytibulars over a 15-year follow-up, a little bit longer than that, but the numbers go out to about 15 years. We've had 80 that have been revised, and so the cumulative percent revision at 15 years is 6.6%. That's good. That's really no difference in the rate of revision for all polytibials compared to modular. We also have fixed modular here, but they're largely the AGC knee, which is no longer used and has done very well. However, there are prosthesis-specific variations. It's always important to note that within all this national data, there are prostheses that do better and some that do a bit worse. So if we look at those, in grey we have the NextGen, the Genesis 2 and the PF Sigma that have all polytibias and also modular, and up to 10 years they have quite low rates of revision. In fact, the PFC we haven't recorded any, but small numbers. However, some have a much higher. For instance, the OptiTrack, again in small numbers, had a quite high rate of revision. So you must remember there are prosthesis-specific differences when you look at national data. So in conclusion, I think there is some conflicting evidence for all polytibias, though in general the rates of revision are similar to modular. I think it's reasonable to use an older population where wear is not expected, and poly exchange is unlikely, except of course for infection, which in the older population is by far the commonest reason for revision. I'd like to thank you, and hopefully at some stage we'll all be able to travel again.
Good morning and Assalamu alaikum to everybody. This is Dr. Masood Umar from Karachi, Pakistan, the Aga Khan University. And for the next few minutes or so, we will be dwelling on the subject of all polytibia and whether it's applicable to our part of the world or not. Just to give you a brief background, about more than 600,000 total knee procedures are performed annually in the United Kingdom, costing about more than $1 billion, more than $10 billion actually. In UK alone, in the last 2 decades, 161% rise in number of total knee arthroplasties was seen, and the regional studies conducted by the rheumatology group in Pakistan, India and Bangladesh showed increase in prevalence of osteoarthritis in the urban population. Back in 1960s, all polyethylene tibia was designed and developed with the intention of it being a thicker poly that would require less bone resection. Initially, it showed excellent survival rates. However, and it came in condyle stabilized and posterior stabilized, both shapes and sizes. However, there were some initial negative reports also published. For example, this one by Hamilton and JBGS 1982 reported 27% failure rate and attributed it to limited plateau coverage. And similar thing was echoed by Fares again, with 68% survival in 10 years, again related to failures related to design of the poly, it being centered on the cancellous bone, leading to early subsidence. Thereafter, cemented metal-backed non-modular components were designed in the 80s, which had greater versatility in terms of polyethylene thickness, in addition of stems and wedges capacity of that. But obviously, that increased the cost. Some more data, the National Registry of England and Wales mentioned limited use of all polyethylene tibial component, 0.6% of their cases by that time. And the Minnesota USA Registry documented the frequency of all polytibia from 3.9 to 12.9% annually. It was 10% in 2008. But why it failed initially, and as I mentioned, polyethylene was only 5 to 7.5 millimeters thick. The relative deficiency of joint congruency and the inadequate surface coverage of tibia were main reasons, and the placement of the tibial component on the cancellous bone led to its failure. Also, in addition, inadequate soft tissue balancing, lack of proper procedure including component malalignment, and improper fixation were also early reasons for early failure. Correct sizing was a crucial step determining overall alignment survival of the implant. Some data about survivorship, which may have already been shared by David, but no harm in having a repetition here. Most of the studies I have put down in this table had about 10 to 20% survival, and as you can see with the last column on the right, all studies except one by Murray in 2014 proved superiority of an all polytibial component. Meta-analysis from 16 published studies with around 6,000 knees found no statistical survival difference between all polytibia and metal-backed tibial groups. And then another level 1 evidence comparing all polytibia with metal-backed tibia showed equivalent long-term outcomes. The Swedish registry mentioned 416 revisions that were in the metal-backed group, and out of 16,000 patients, and 216 in the all poly group out of 11,000 patients, almost a similar outcome. And there was no clinical evidence at that time showing different infection eradication rates between a very important component between all polytibia and metal-backed tibia components where debridement and component retention was undertaken. Now coming from survival analysis to the economic analysis, in 2006 Muller and colleagues proposed a cost saving of $39 million per year across England and Wales if just 50% of 70,000 total knee arthroplasties performed annually used all polytibia. If all patients in the registry, which is 16,500 over a 14-year time period, aged greater than 75 years, had an all poly tibia instead of a metal back tibia, the cost saving would be greater than $1 million US dollars. James cited cost of primary knee replacement was on average $1,000 less with all poly compared to metal back tibia. Another study, 20 to 30% cost difference was also noted. Another factor in overall cost effectiveness was the relative revision rate of the respective components. However, the best available data show that modern all poly tibia have revision rates equivalent or superior to that of metal backed implants. Multiple randomized radio-stereometric clinical outcome studies and 2 recent systematic reviews have suggested equivalence or superiority of the all poly tibia design over metal back tibia in terms of failure. Pakistan, where I live and I have grown up, the cost of a metal back Johnson & Johnson prosthesis, for example, is about 2.48 lakh Pakistani rupees, which is equivalent to $1,560 US dollars. And if we convert that into an all poly tibia, the cost is about 1.7 lakh Pakistani rupees, which is about 1,060. So a net saving of $500 US dollars for a unilateral knee. And when it comes to self-paying patients, which 95% of our patients are, it becomes a significant difference. Candidates for all poly tibia in total knee arthroplasties mainly are of low demand. However, nonetheless, it is also recommended for younger patients, also with rheumatoid arthritis patients. This was a study for all poly tibia and rheumatoid arthritis patients, published in CCOT Journal in 2012, which showed a survivorship analysis 100% in 10 years and 87% at 25 years. So to conclude, all polyethylene tibial component is an appealing and cost-effective alternative and is associated with the excellent survivorship with low risk of infection and revision. In light of the present-day economic evidence and long-term functional outcome, all polyethylene can be a very cost-effective alternative to the metal back implant. Irrespective of age, it is as good as a metal back implant. Further studies are needed that the expected number of younger patients younger than 65-year-old who need total knee arthroplasties will reach 55% of total joint arthroplasty patients. We recently, for anybody's reference, published this review article in Annals. I thank you for your attention. Thank you.
Well, hello. I hope you're enjoying yourself. We've tried to give you as much of an overview of total knee replacement as we can, and some of the controversies and stuff. I'm sure you have questions to ask us, and we've already got some from you. Thank you very much for those. We will proceed with just answering your questions. And for the first question, which is, what are the different design characteristics of medial pivot design and posterior cruciate stabilizing total knee prosthesis, and how do they perform in terms of knee stability? I would like Professor Yan-Chun Hoi to start off on this, please.
Right. Thank you very much, David. I think the medial pivot design and the posterior cruciate stabilizing or PS knee design, they are not mutually exclusive. They're just describing different things. There could be some overlap between a medial pivot and a PS knee design. For example, the medial pivot knee design, theoretically, it's based on asymmetric poly. Because the medial side is more conforming, the typical medial pivot knee design, the medial side would be a ball and socket joint. So the stability, antero-posterior stability is provided by the high anterior and posterior lip of the poly. On the PS knee design, then the AP stability is provided by the cam and post design. But they are not totally mutually exclusive. If you look at some of the modern knee design in the market right now, a lot of them have this asymmetric poly. They also try to mimic the medial pivot kinematic of the natural knee. Based on some early literature report, some studies show that if the medial pivot knee can be mimicked, in the total knee arthroplasty after the surgery, then the patient satisfaction and the early recovery will be better compared to the conventional total knee. But I think this is also very early data, and the sample size is relatively small. I also did some medial pivot knee and then conventional PS knee. Based on our own analysis, we didn't see any functional difference between the two different designs. So they are not mutually exclusive. You can have the medial pivot knee with a PS design, or you can have a medial pivot knee with a CS or CR design. So there are two different concepts. All right, that's my answer.
Okay, that's very interesting. Richard, where does the data stand on this in the Australian registry?
Well, we have about 25,000 medial pivots designed over and 500,000 or 600,000 knees. And we find that the lowest rate of revision continues to be with the Cruciate retaining knee, so the CR knee. We've got about 6 or 7 different designs of medial pivot, and they're relatively new. There's been a few around for several years, but overall, certainly the CR knees continue to have the lowest rate of revision, and the medial pivots so far haven't proven to have any significant advantage compared to a standard CR knee in terms of revision surgery. I can't comment on patient outcomes, but we'll have that data at the end of the year with our patient-reported outcomes data. So we'll be publishing that towards the end of the year.
I think Masood and I both have virtually no experience with middle pivot knee, and Masood, you've got a smaller experience. What's your opinion of that?
I'm very happy with medial pivot knees since they mimic the normal physiology, but again, very limited experience. So far, no complications. I agree with my colleague there. They are very similar to the concept of posterior stabilized knee, and depends on what you are comfortable with also, and what is your training. So nowadays I'm using mostly posterior stabilized knee. I am not using medial pivot anymore. But again, no complications.
Okay, so the short answer is we don't know as yet. So far, it has not proved to be an advantage, and only time can tell. So the second question is, how would you choose an implant for a patient with severe varus and flexion contracture deformity? I will tell you, of the 4 of us, the person most experienced with this is Professor Masood Umar, and I would like him to give us his answer.
Well, my answer is straightforward. Posterior stabilize. I think when there is such a severe deformity, which we deal with very frequently, most of the cruciates, we hardly see the anterior cruciate, and even the PCL has been attenuated and shortened. So in order to have a good functional PCL, it's very difficult. In the cases I have done, so I err on the side of resection and doing a posterior stabilized balanced knee after my, obviously goes without saying, to have a much better soft tissue correction on the medial side and the posterior side. But I always err to use a posterior stabilized knee because I don't rely on the PCL, and most of the time it is missing, or as I said, attenuated and short. Thank you.
Professor Yan Junhai sees a lot of Chinese patients with this problem. What do you think, Junhai?
Yeah, I agree with Professor Umar. For patients with a severe varus and severe flexion contracture, it's very difficult to do soft tissue release if you keep the PCL. Because of PCL, if you keep it, that would tighten up the medial side and also tighten up the extension gap. So for patients with severe varus and flexion contracture, most of the time I would do a PS knee.
Okay, well, you know what, guys? I just have a different point of view because I didn't train that way. My religion is different from yours. I almost never do a PS knee. I always do a CR knee, no matter how bad the deformity is. And my personal opinion is that, you know, the correction of a contracture is more a soft tissue thing than it is due to selection of implants or anything. And the more soft tissues you preserve, the easier it is for you. And the PCL is one of the most important things to maintain the distance between your femur and your tibia at the end of the procedure. And I think Richard will say that actually, in terms of longevity, and he just said it just now, a CR knee lasts longer than the PS knee. Yeah, Richard?
Yes, I mean, we've got a half and half in the panel here. I try and preserve the CR, and I do the release in other areas, and I take a posterior osteophytes out, I release the posterior capsule, but I almost always preserve the posterior cruciate ligament as a rule.
Well, now to question 3. Question 3, can I look at it, please? Question 3, what are your indications for cruciate sacrifice or cruciate retention? There's a very, very simple answer to this. It is, what is your religion? If you believe in preserving the cruciate, you will. If you want to sacrifice it, you will. But as Richard has already said, the evidence in longevity favors cruciate retention. Chun Hoi and Masood, I know you guys don't believe us. So I guess
rheumatoids should be a challenge, David.
Actually, no, we also discussed that. I said you have less bone loss with cruciate retained knee implants. That's the thing. I don't know. Richard, you see more rheumatoids?
Well, I think that's the interesting thing. Rheumatoids made up 8% of our knee population 20 years ago. They make up 0.5% now because the biologic drugs have almost completely revolutionised knee replacement for rheumatoids. It's only the old burnt-out rheumatoids and the severe valgus that have now come through. So we've had a very different picture in Australia because of the biologic drugs. But again, I almost do see... I worry about the box taken out with these little tiny rheumatoid ladies, and the time you take a beat, I tend to try and preserve it. Even with 20-degree varus or valgus, I try and preserve.
Okay, well, to question number 4. Question number 4, can you scroll up? Yep. Question number 4 is what's probably mine, because that was my talk. What's the effect of all polyethylene tibial component on load-bearing stress, insertion, and stability of the knee joint? Well, my simple answer is listen to my talk. It's a 10-minute talk and covers pretty much everything of what you need to know. If you look at biomechanical studies of this, if you look at any analysis you want, actually the all polytibia components are the most stable, and it's just that we've been educated to believe the reverse. Richard, well, how does that show up on the registry?
I think all poly components, of which we have quite a number, certainly in patients over 65 do very well. Their outcome in terms of revision rate is the same as modular, or what we call the unipolar modular, where the poly is moulded onto the base plate, such as the AGC knee of Biomet. So they all do roughly the same. There's a few characteristics and there's a few differences amongst the all polytibias, but I think as a rule of thumb, and in the patient population over 65, the outcome is exactly the same. So agree there.
And Chun Hoi had wonderful news for me, because he says in Mayo, they also believe, some surgeons in Mayo also believe in cruciate in all poly knees, yeah?
Yes, that's true. When I was Mayo many years ago, I saw these big shot surgeons. They're still doing all poly knees, and they told me that their results was excellent. So I believe them. I think the all poly knees perform quite well. The problem is I don't have any experience with them because they're not available in Hong Kong, and I think that's probably a business more strategic choice by the implant companies, because they just don't introduce low profit making implants to a country. So I have to believe the literature and the other trustworthy surgeons' words.
Well, Masood's point of view is that they are good. Isn't that what you said, Masood?
Well, as I showed in my presentation, cost is a big saving with all polytibia, and we in our part of the world, patient is paying from the pocket, totally paying from the pocket. Less than 5% of patients are insured. So if we can save good 20 to 50,000 rupees on doing an all polytibia, and the long-term results prove the benefit of its longevity and stability, then why not? Why not? So I would go for it.
So the question number 5 says, would you use it in a fat patient? I would. if I could get enough stability for the poly, because sometimes when we talked about this just now, sometimes you just have to stem it, otherwise it's not stable. In that case, you have no choice. You can't use an all poly. But that would be rare in my experience.
I'll
Richard,
speak up for Australia. Unfortunately, a third of our patients have BMIs 35 or greater. So it's rather embarrassing to actually admit that statistic. So we tend to stem tibias in that situation, and even add a short stubby stem to the existing I-beam type stem. So, and that's a third. A third of patients are in that category, which is rather alarming. And I probably wouldn't use an all poly tibia in that group, because I'd always put a metal stem down, to be honest, in that heavyweight population.
Can we scroll down to question 7? And question 7 is basically, would you use gap balancing or measure resection? I don't think in my practice it makes any difference to me. I just do what I feel is necessary. What's yours? Do you have a set way of doing it, guys?
Well, I think your previous answer also applied to this question. It's a religion, right? If you look at different surgeons' technique, you look at the meta-analyses, systemic review of literature, I think there's no difference in the clinical outcomes in gap balancing or resection, measured resection, because we know we have a limit of cutting the bones. You don't want to cut your bones out of the way. And at the end, what you want is a balanced knee with good alignment. And I think most of the surgeons nowadays would use a hybrid technique. So it's a combined measured resection with gap balancing within a reasonable boundary. I think that's most of the surgeon would do. That's definitely what I am doing right now.
I think the argument's been kinematic versus mechanical alignment. I think everyone's kind of coming a bit each way and not straying too far out of mechanical alignment. But at the same time, I use pressure monitors and a robot so I can get fairly good information for my knees. And I think we're finding more and more that's a little bit of balance and not straying too far out of a reasonably good mechanical axis is probably where we'll end up, and to avoid extremes. I think the evidence for mechanical alignment's reasonably good at 20, 25 years and for navigation. So I think I'd be a little bit wary when I see 7-degree, 8-degree tibial cuts to kinematically balance a knee. I'd be very wary of that at the moment, but there are certainly some surgeons who do that. So the evidence is not quite there, but I don't think I agree. There's not much difference. It's how you were taught, and as long as you get good balance and reasonable alignment, you should, and use a good knee, you should have a good result.
Okay, I'm just going to answer question number 8 quickly. Can I get it? Question number 8 just basically says, Sadi, basically, if you need to augment bone with screws and cement, just do it. If you looked at my paper, you look at my presentation, it's a very stable construct. It will not fail. Question number 9, what do you think of constraint? We've also covered that because we've only got a few minutes left. And actually, pretty much constraints, some people think it's good, some people think it's not necessary. In terms of longevity, less constraint in like a CR implant is actually not bad for longevity. And question 10, explain techniques and key points of soft tissue balance. That's a 2-hour lecture, okay, guys. You just have to be good at what you're doing. If you're good at what you're doing, you put anything in, it'll work, okay? Do you agree?
Yeah, I agree.
It's a soft tissue operation, I agree. Balancing the knee, yeah.
Okay, I think pretty much we're covered. And we have 1 minute left. So with the 1 minute left, I would like to thank Asia for inviting us and giving us a podium to express our opinions, particularly mine. Thank you very much. And I'd like to thank my friend Chun Hoi, Masood, and Richard for supporting me in this endeavor. Thank you, guys. Thank you so much. Bye.
Thank you, David, for inviting.
Bye. Bye-bye. Take care.